Yes, wonderful. So welcome. This is track one, prize, the first set of prize talks. We have two talks today. But before that, let me introduce you to our judges. They're all on the session as attendees. Stephen Harsono, he's the head of public health for IQVIA Asia Pacific. Pascal Leroy, she's the vice president of healthcare sector at the William Davidson Institute here at the University of Michigan. Azuka Okeke, she is the CEO of Africa Resource Center at Nigeria. And finally, Kelly Hamplin, she's a program officer at the Bill and Melinda Gates Foundation. So here's the structure. We have two teams. Each team has about 25 minutes to present. We'll follow that by Q&A from the judges. We'll open the Q&A for the judges. We'll give them preference. And then as time permits, we will have audience ask questions as well. Feel free to unmute yourself to ask questions. If you want to switch on your video, it might be okay, but it may be bandwidth heavy. That's why when you ask a question, you might, I would suggest you can unmute your video. So the first presentation is COVID Action Fund for Africa. Here are the authors, and they have submitted a video. So I'm going to try and play that video just now for you.
My name is Vicky Rameau, and I am the Communications Manager for the COVID-19 Action Fund for Africa. In August, 30 of the world's leading community health organizations announced the COVID-19 Action Fund for Africa, a radically collaborative initiative to mobilize resources to provide personal protective equipment for 1 million community health workers serving over 400 million people in over 20 African countries. The COVID-19 Action Fund for Africa, CAF Africa, works with governments to support ministries of health to aggregate and address the unmet need for COVID-19 related supplies for community health workers. To date, 12 countries have received up to a 6-month supply of PPE, including Côte d'Ivoire, the Democratic Republic of Congo, Lesotho, Liberia, Malawi, Mali, Mozambique, Rwanda, Sierra Leone, Uganda, Togo, and Zimbabwe. The fund has made a big impact quickly, but there is much work to be done to safeguard essential health services at last-mile communities. Over the coming weeks, CAF Africa is mobilizing additional resources to get PPE to CHWs in Angola, Ethiopia, Kenya, Nigeria, and Zambia. Community health workers are the lifeline for health services for millions of African citizens. We must prioritize their safety during this pandemic. While the challenges are great, they are not insurmountable. CAF Africa, with the support of the World Food Program, has delivered over 275 tons of PPE from China to last-mile communities in Africa. We've got a lot more work to do. Please welcome Dr. Madeleine Ballard, Executive Director of the Community Health Impact Coalition.
Basically, as COVID-19 spread in March, the demand for PPE grew by a factor of 100 and prices skyrocketed. And so a global shortage of gloves, masks, and eye protection obviously affected all health workers. But it quickly became apparent to the Community Health Impact Coalition back in March that the brunt of this shortage was falling on low and middle income countries and community health workers in particular. Not only was there an absolute shortage, but there was a major distributional problem as well. We saw in country after country that CHWs were being excluded from national PPE projections, despite the life-saving work that they undertake. And this is having devastating consequences. While we know that everyone is quote unquote over hearing about COVID, COVID is unfortunately far from over. As you can see in the animation running on the screen behind me, cases in Africa continue to rise by 6% every single day. We are mid-emergency. Community health workers are, meanwhile, at the front lines preventing, detecting, and responding to this outbreak. Yet without PPE, they put themselves and their patients at risk. In every country, and I want to make this clear, in every country covered by the fund, all 24 countries, CHWs are relied on for services as diverse as malaria testing, providing vaccinations, malnutrition case management, case finding, home-based care for COVID patients. And this is the critical part. None of what I just mentioned, none of these services can be done over the phone from 6 feet away or with only a homemade mask. And it's reductions in precisely these types of services that often kill more than the pandemic itself. We saw that during Ebola, and we're already unfortunately seeing this now due to the lack of PPE for frontline workers. Moreover, CHWs go house to house. So without PPE, they risk becoming disease vectors themselves. And we've already seen, again, following the drop in access to protective gear on the continent, there was a 203% increase in COVID-19 infections among healthcare workers. And this is in the context, of course, of an already acute health worker shortage. Meanwhile, the evidence couldn't be clearer. A recent JAMA article, the first study actually looking at PPE for CHWs in COVID, found that without complete PPE, nearly 1 out of every 5 CHWs were infected with COVID. With complete PPE, so a mask, gloves, face shields, none, 0% were infected whilst carrying out their door-to-door duties. If we had a drug that worked that well, we'd be sending it to every health worker on Earth. Yet, in communities around the globe, CHWs, who are the face of essential services, are still going without this essential tool to continue their work in providing essential services. I'm going to tell it to you straight. The unequal distribution of PPE, we think, reflects the existing biases about the worth of the life-saving work that CHWs do, and it needs to be corrected. There needs to be a preferential option to correct it, and that's what we tried to develop here. PPE, from an epidemiological standpoint, very clearly should be distributed based on the services provided, not on the service provider. And that's what we all got together here to correct. So to address this problem, this amazing team worked with countries to scope and actually quantify PPE needs for CHWs providing essential health services in 24 African countries. And basically, as Muhsin shared, everything that this fund is doing is 100% evidence-based, verified with ministries of health, and based on these verified projections. And our rapid analysis, and you can see that on the screen here now, found that the need for PPE was immense. Over 400 million pieces of PPE were needed to protect these workers, to maintain the essential health services that, again, so often get disrupted during pandemics and are at risk of being disrupted literally as we're speaking to you now. But to respond to this crisis, we did what so many of the organizations involved, and as Muhsin mentioned, there are over 30, plus all of our Ministry of Health partners. We put in place a plan to both meet this acute need, because again, we're in a crisis, even though it might not feel like it, we are absolutely in a crisis. You saw that case rate climbing, while at the same time building health systems for the long term. How can, at this moment, we use PPE as a wedge to further institutionalize community health workers within ministries of health and within health systems across the globe.
Now we'll hear from Tapiwa Mukwashi, Senior Manager Supply Chain from VillageReach.
So our solution has been to embrace radical collaboration to protect community health workers. And this has been seen through a shift from the traditional approach where organizations have been viciously guarding their pursuits to one where organizations welcome deep collaboration. As highlighted by Madeleine, under the CAFA initiative, 30 organizations spanning 24 countries in sub-Saharan Africa have come together to cooperate in establishing a supply chain operation to deliver PPE to the last mile as part of a coordinated emergency response effort. I want to go over 3 strategies that have been important in this work. We knew that in order to mobilize resources, we had to accurately quantify what was needed to protect community health workers. We hear over and over again that we needed 448 million pieces of PPE. And to achieve this figure, we undertook a joint determination of need. This included one, a quantification and a gap analysis. And to achieve a broad buy-in to allow organizations to rally behind the quantification, we used a participatory approach that recognized national systems, that recognized national structures established to focus for medical commodities within the ministries of health. And so we worked jointly with several organizations who work under the Community Health Impact Coalition and the Community Health Acceleration Partnership across the 24 countries to support the ministries of health in inputting assumptions related to community health workers, the number of community health workers serving in different locations, the type of PPE that was required to provide the services that they were authorized to do. And it was very important for us to ensure that this quantification was done under the ambit of existing structures and mechanisms, because we want to ensure that this effort adopts a system strengthening approach in a way that where a system to focus for community health workers does not exist, we contribute to establishing it. Where a system exists to focus for community health workers, we provide additional technical support that ensures that the community health workers are recognized, included in supply planning and the following budgeting processes. And through this process, we have been able to see that a number of ministries of health across the 24 countries are now more aware of the number of community health workers working on different projects in the geographies that they provide. They are prioritizing community health worker interventions in that they are including in supply planning processes, last mile logistics, all the elements that are required to receive and deploy items to the community health workers as needed. So we recognize that community health workers need to be protected now, but they also need to be protected into the future. This is a long-term thing. This is not a stopgap measure to just protect them now and vanish once the emergency is gone. And so we are looking at the processes, working with the ministries of health with a long-term focus, and that's why we are following a systematic approach. And in a big way, this initiative is allowed for the ministries of health to see that community health workers are important and must be integrated into planning and budgeting, to allow for us to create efficiencies that traditionally are missed by many players in the sector around procuring at competitive prices, procuring in large quantities. We established a pooled procurement mechanism leveraging on the competencies and expertise of direct relief. And so a number of the orders that different partners were meant to be procuring on their own on a non-competitive basis were pulled together, leveraged on an order platform created by direct relief. And this has seen us, I'm saying this because we've benchmarked the prices that have been achieved by direct relief with what is being achieved by other partners. So we're getting competitive price, we're getting competitive delivery times, and this has been very good in creating the efficiencies and effectiveness that are required in this initiative. I like this slide for one thing. The graphic here gives a full story about how we have many players in this sector who would ordinarily be competing in the geography, coming together under one voice to work with an entity that has the capability to procure across 3 continents, to arrange the first mile logistics related to whether it's air shipments, ocean shipments, in delivering them to the points of entry across the 24 countries. We've worked with in-country partners to support the Ministry of Health in supporting middle mile logistics, customs clearance, staging and storing the items at the central medical stores, and repacking the commodities into kits and delivering them into the last mile. So this whole coordination, this whole cooperation amongst the stakeholders across many geographies really points to a radically collaborative mechanism which has a capacity to continue benefiting community health workers and elevating and prioritizing them into the near future. Thank you.
Thank you, Tapiwa. And now we'll hear from Thomas Teague, CEO of Direct Relief.
Everybody who's taken the time to join us today, it's a privilege for Direct Relief to be part of this collaboration and this global coordinated effort. You know, the old joke is everyone is for coordination as long as they are the coordinator. And that is not the case here. I think it's a rare privilege for us to be part of this. So I think the slide that's up right now, you can see what the progress has been. I think it's 42 million units of PPE, 12 countries so far. I think we're breaking it down by the type of product. And just as kind of a couple of contextual points I think are important, at least from my perspective. Direct Relief, this was the largest purchase that our organization has made in 72 years, other than the building that we built so that we could be an accredited drug distributor. As a signal of the seriousness with which our organization takes this. I think, as Madeleine and others have said, that the role and importance of community health workers is unquestioned. We saw it in Ebola. We see, you know, in the United States, Direct Relief is supporting community health workers here for the exact same reason. They prevent hospitalizations. They detect disease early. They keep people healthy and out of the hospital. It's a low cost, high value, high impact investment. And it's unfathomable that they're last in line for support, but they are. So I think the effort is to really mobilize the private philanthropic resources as the public institutions are clearly overwhelmed. By way of contrast, you know, the WHO reported recently what their provision has been for this effort. And I think you can see, they reported that they've been able to provide 3 million surgical masks, and the consortium has delivered 22 million so far, plus 500,000 KN95 masks. WHO reported that they were able to provide 2 million gloves. The consortium has provided 35 million. WHO reported they could provide 200,000 surgical gowns. The consortium has provided 975,000 so far. WHO reported they could have provided 100,000 face shields, and the consortium has provided 850,000 so far, and we're still far short. So I think that, you know, as an example, that's a pretty sobering reality, and it's not a criticism of WHO. It's an observation of what's needed to complement their efforts, and those are the ministries. It's unreasonable to expect that here in the United States, where we're struggling to just do PPE, that we can expect countries with far fewer resources to mobilize and connect them on their own without some help. So I think the idea and the urgency of it has been clear. The value of community health workers is proven. And so it's been a real privilege for Direct Relief to join with the 29 other groups and put forward both what we do, and work with all those. For everyone listening, I think it's, you know, it's a rare occasion where, you know, everyone's expertise and what they bring is leveraged by everyone else's, including anyone who contributes funds. The groups are using what they've got. They're not charging this fund to do it. This is what they do, and this is what Direct Relief does. So I think it's the photos you saw if you tuned in early of the flights leaving from Shenzhen. That was World Food Program. That's the backbone kind of operational arm of the United Nations. They agreed to haul this for free. So it's been 240 tons on 11 cargo flights that, had we done it even at low cost, it would have been $4 to $5 million in costs that have been averted. So really the funding pool is to just obtain the items at the lowest cost possible. And we've been very fortunate to be able to do that. Direct Relief's cost of goods obtained is usually zero because companies like 3M and BD are so generous with their product contributions. That's not possible in this case as the world market has been so upset, prices remain high. And I think when we have been able to go out and purchase with the $10 million that Direct Relief put forward, followed by the $2.5 million that the Crown Family Philanthropies put in, which was astounding. The pricing that we've been able to get, it's discounted because it's not a commercial arm's length transaction. People understand the groups involved. We have no agenda. We're just trying to get help with really right now a relatively small pot of money to people who don't have it, won't get it otherwise, and need it now. I will add that direct relief works in emergencies, and one of the things you learn is that an emergency means you've got to move. You cannot analyze global warming in all of its context when there's a fire burning outside town. So I think you have to do it thoughtfully, but it has to be done fast. So I think it's a privilege for us to be part of it. We're committed, obviously, deeply to seeing it through. And for anyone who's in a position to participate in any way, please know that you will get the best efforts of all 30 of us collaborating partners.
Thank you, Thomas. And now we'll go to Sierra Leone to meet Ramatu Usman Jallo, a community health worker and supervisor with the Ministry of Health and Partners in Health in Sierra Leone.
And protecting community health worker is like if you are protecting the whole nation. Because the community health workers, we are the frontliners, just as you said. And most of us here in Sierra Leone, we are victims of HIV positive. So our immune is very low. Quickly to collect different diseases from other patients. So during this COVID, the best thing you have ever done is to protect us, because it gives us confidence to do our job. Because we are the bridge between the community to the facility. And mind you, we are dealing with local people. Sometimes social distance is very hard to maintain because they're used to us, not just for COVID. We are community health workers for different types of diseases, especially HIV and tuberculosis. They're used to us before COVID, coming very closer, right? So just because of COVID, we cannot just keep off from our people. So protecting us is the best thing for the whole world. CHWs, where you protect CHWs, you protect the nation, right? So as I'm here as a frontliner, I really happy of being protected. So PE is necessary for me to do a better job because it gives me the confidence to go closer, to move to the last step, the last door, right? So it's very, very important. I think it's not just PPE for all, but PPE forever for CHW, right? Because we go out there, meeting with different affected people, then coming back home to meet our own people, you know, is very risky. So PPE forever for CHW, I advocate for, right? So I don't think I have to go further. It's just, I'm saying here, it's necessary for community health workers to be protected forever because we are there to do every work for everyone that needs assistance. PIH have done a lot. They have taken us from somewhere. Then we want to take people from somewhere too, right? As you can see, PIH have changed my life from being a patient, now at least supervisor that we supervise people that look after sick people. And I enjoy doing the job. Thank you very much.
Thank you, Ramatu. Community health workers like Ramatu test and treat malaria, they do assessment for malnutrition, and they support pregnant women. They also provide community education on COVID, and they can increase practices such as universal mask wearing, as well as referring suspected COVID-19 cases. Our objective at CAF Africa is to create a virtuous cycle where community health workers can maintain essential health services while allowing them to safely prevent, detect, and respond to the coronavirus. But none of that's possible without PPE. With PPE, there's a virtuous cycle of supported community health workers, ensuring safer and healthier communities. We must protect community health workers and provide them with the PPE they need, not just today, but always. Thank you.
Okay, wonderful. Thank you so much. I think, was that Tapiwa and Mila will take questions. So please switch on your videos. May I also ask the judges to switch on their videos, and maybe between Stephen, Pascal, Kelly, and Azuka. Let me start with maybe Stephen. A question for the team?
Yep, absolutely. Thanks, everyone. Great presentation, and really helpful to hear about the initiative. And I think, I think the problem statement was really clear, and how you went about it was also really clear. I think that the pieces that maybe didn't come out as clearly for me that I'd like to hear a little bit more about is contextualizing the impact a little bit more, right? So in terms of the total need that you were able to meet, in terms of number of community health workers that you cover over the total, in terms of what your sort of relative impact is compared to other organizations, how much of that need is met, and then sort of thinking about it from like a value for money in terms of the cost relative to reaching it, would be great to get a few more fast facts on if you have them.
Sure, maybe I'll try, and then I'll ask Tapiwa to weigh in. So first of all, what an honor to be with all of you. Thank you so much for having us here. So Stephen, to answer your questions, so the first one around contextualizing impact. So our goal was to reach 1 million community health workers. This was based on a fairly extensive but rapid literature review that we did to just get an up-to-date understanding of how many active community health workers there were on the continent providing services. So that was what informed the goal of 1 million across the 24 countries that we knew from the review that we did that relied on them. And it was a combination of literature review, discussions with governments, implementing partners. So a fairly thorough, rapid process. To date, actually, we have made orders to reach about 500,000 of those. So I think we're tracking fairly well. Not all 24 countries that we scoped in the review have ended up being, sort of responsive, that's the right word, in order to move the donation forward. So, it was sort of a process of scoping the need and then moving towards action with the fund. And when it came to the part of moving towards action, we really just plowed ahead with all the countries that were responsive in terms of being sure they could feasibly deliver the goods to that last mile. So of the 24, we're now working closely with 18. The 500,000 figure I mentioned is for 16 of those. So actually from the presentation, we've added on a few more countries since then. And then the value for money point, I think what's made this really unique is the pooled purchasing, which I feel like is a theme throughout this day. Essentially, that's what this whole effort facilitated that wouldn't have been there. So for instance, some of our partners like Last Mile Health, Partners in Health, a number of others have tried to procure PPE earlier on. Their prices were much higher, their timelines were much longer. And I'll actually, maybe Tapiwa, you can add a bit on that, but that's sort of what's made this unique and a value for money play.
Good. Kelly, you have a question?
Yeah, thank you. Great presentation. Thank you all. I was wondering if you could speak a little bit to the approach that you took to manage potential skewing of the demand forecast, given the acute nature of the response. So how do you protect against trying to inflate what your actual demand is or the absorptive capacity, given the to receive product, given the perceived high demand and actual high demand globally? Forecasting is hard in general, is particularly hard in this environment, of course. So what were some specific approaches that you took to manage that?
Thanks, Kelly, for that question. And you are right, focusing in an emergency can be very difficult because of the absence of data or correct information to inform a particular forecast. So a number of things that we did to ensure that our forecast was not way too skewed. But I must underline this and say, of course, this is an emergency, and the focusing approach really underlies the no regrets basis. For whatever purpose, we will have figures rather than not have figures at all. And we will procure just enough to allow us insight into the extent of the emergency and the actual information on demand. So we wanted to procure 3 months initially so that we could then procure the second order based on information, but we also took note of the logistical challenges, the border closures, the significant delays at the ports of entry, and we altered to, going with 6 months just to make sure that those logistics constraints did not affect our ability to make sure that the community health workers were provided. So on an ongoing basis, we've been calculating the mean average performance error to see how variable between what we actually procured based on the assumptions, how much community health workers do they use per day, the PPE they use per day, the number of patients that they are likely to see based on the number of hours they, so we've tested those assumptions and we've continued to review them. And this is informing all the planning that we are actually conducting to resupply the community health workers. So we leveraged more on managing the supply pipeline rather than spending too much analysis on the actual numbers. Are they correct? Are they incorrect? We knew the information because of the different community health worker organizations that are supporting the governments. They would relay the information that would allow us to review the upcoming orders. Thank you.
Yeah, thank you. Azuka, any questions?
Thank you. First of all, great presentation. It was easy to follow through and to see all the partnerships just to have this happen. My question, I think, is with regards to the quantification and where you mentioned that you did this, comprehensive groundwork quantification together with the ministries of health. Can you talk a little bit more about that? What was the role of the ministries of health, particularly as I heard the community health worker in Sierra Leone, fantastic, when she said, not just for now, but for, for a lifetime. How does that work? Is that part of what they will continue doing? So thank you.
Sure. Yeah, so to be clear, I think community health workers have never needed this much PPE. I mean, at a minimum, they've needed gloves for malaria rapid diagnostic tests, but certainly not masks or face shields. So this was something no one really understood when COVID-19 hit us all. And so we, but there was a recognition, as conveyed well in the video, that this was so important. The whole community health advocacy movement. We were, kind of struggling to figure out what we would do, and you can't fight what you can't quantify. So although this hasn't been done before, and although there isn't, well, there's now, but there wasn't quite a database of community health worker programs, we set that up. And to do that, we needed to not only look at the literature, I mean, that was sort of an easy-ish task, but also to validate the information that we saw, that we were seeing from partners on the ground, and to the extent that we could directly from government. So we relied very much on partners. The Community Health Impact Coalition is a coalition of community health field practitioners who are all operating across the world, strengthening community health systems with governments. So we worked very closely through the membership of CHIC, and then through a number of other, frankly, just leveraging our network. I used to work at CHI, so through them, we have direct access to some governments through the Community Health Roadmap, which works directly with governments. So it's really kind of a quick who knows who exercise to try to pin down the assumptions. So that's what we did.
Thank you.
But actually, it will be, I do think this is a new reality that everybody's adjusting to. And this is something that community health workers and other frontline health workers are going to need for the foreseeable future, for sure.
Pascal, do you have any questions?
Yeah, just a short question. So ECHO is a wonderful presentation. I really enjoyed it. And the short-term objective was very clear to me. I wanted to ask a question related to the long-term objective and what you see as success. So I understand education of the Ministry of Health and the importance of the community health workers is a huge part of this project. But what is success?
I can, sorry, maybe Tapiwa can weigh in. I think success is a few things. So one is that these community health workers actually get all the stuff. I will say it's still a work in progress. Glove shortages have been a huge hurdle. We seem to have cracked that today, but that's number one, that they're there. I think the second point is that all of the quantification that we've done that's been validated with the processes Tapiwa outlined before, as they get the stuff, all of that then feeds into future proposals and resource mobilization efforts by these countries. So both on the domestic side and also on the institutional side. And so we're also tracking that. And then the third is that this now becomes routine. You know, the inclusion of community health worker needs is not just sort of in an emergency, like with Ebola, oh, we have to protect them, but is actually ingrained in the processes for PPE and for other essential commodities. Tapiwa.
Thanks, Mila. Just to add that success also looks, we consider success when community health workers become integrated into the routine quantification, routine supply planning, routine budgeting across the 30 organizations that we are working with. Most of them have played a very key role fundraising to procure commodities for community health workers, but this is not sustainable. It is only sustainable when the budgeting, the procurement, the planning is done through government. And so we hope this exercise, which has involved the government selecting the PPE that's relevant to community health workers in their geography, how they have reviewed the algorithm that was developed to inform the forecast, how they have thoroughly contributed to providing the assumptions that went into the algorithm. These are some of the key capabilities that have been built that allow for this to be done now and this to be done repeatedly into the future. So we're looking for a future in which community health worker supply needs are integrated into the Ministry of Health supply planning and budgeting. Thank you.
Well, that's all the time we have. Thank you so much, Tapiwa and Mila, for your team. And we will now switch to the next talk. So let me do share screen again. And so our next presenter, our next topic is really the optimizing supply chain management for efficiency using commodity order management system. They also have submitted a video. I just want to make sure who is here from the team to answer any questions. Just a quick check. Could you just speak up? Who's here?
Abubakar Mohammed is here, and
okay.
Jonah.
Okay, Jonah and Abubakar. Okay, cool. So I was told like I need to present the video. Is that correct? This was submitted. So let me play the video.
We want to speak through. Good afternoon. Good evening.
Yeah, are you going to present your
My name is Alhaji Mohammed, Data Analytics and Reporting Manager on the USAID Global Health Supply Chain Program, Procurement and Supply Management, GHSC-PSM. And with me on this journey is Jonah, Dienye, MIS Manager, Supply Chain Information System.
Guys, are you able to hear this and see? Okay, wonderful.
I will be presenting on supply chain management for efficiency using the commodity order management system, COMS, in Nigeria. As a background, Nigeria has benefited from technical assistance from different development partners, USAID, UNFPA, the Global Fund, etc., etc. And these technical assistance include different innovative solutions and use of technology, primarily to improve efficiencies, optimize processes, and bring about cost savings, specifically looking at supply chain landscape and supply chain operations. On this project description and context, the GHSC-PSM in Nigeria ensures uninterrupted supply of HIV/AIDS, malaria, family planning medicines, and commodities across 36 states and the Federal Capital Territory. The project works with the government of Nigeria to manage health commodity supply chain data through an innovative tool, the Nigeria Health Logistic Management Information System, NHLMIS. The project also supports last mile delivery of health commodities from 6 axial warehouses or distribution centers to about 17,000 service delivery points or health facilities near the households of our patients or closer to our patients. What was the problem? And what intervention did the deployment of comms address? Number one, orders for last mile delivery were completed manually using spreadsheets. In this instance, in our experience, it was Microsoft Excel spreadsheet. The process itself was very, very cumbersome, which was prone to human error and requires a great deal of back and forth communication, which can cause delay lasting as much as 72 hours every delivery cycle. To cut down on these errors and to streamline these processes, the GHSC-PSM introduced the Commodity Order Management System, COMS, in early 2019 that includes a direct interface and visibility between warehouse management information system and the NHLMIs. So upon the deployment of this tool and its development, we commenced rollout across project sites, specifically which commenced in May 2019. Last mile delivery orders from COMS were electronically received for the first time by the Calabar Distribution Center or the Axial Warehouse after a successful test at the development phase at the user interface. And by November 2019, the COMS itself has been rolled out to cover all the 4 axial warehouses. They started to receive orders electronically. Below that is a snapshot of COMS tool and an operating interface. With the success of the warehouses or distribution center receiving orders electronically, we increase the scope of our rollout to include electronic proof of delivery, which is a system that was used to deliver commodities in the last mile. This rollout also started with Calabar Distribution Center, and the state which was benefited from this system was Akwa Ibom State. And this happened in November 2019. With the success of this rollout, it was extended to Sokoto warehouse or Sokoto distribution center. And we added additional 5 states, which included Sokoto State, Kano, Katsina, Jigawa, and Kebbi State in January 2020. That is the story. But then, what was the process like before? And what is the process now after the deployment of COMS? The snapshot here tell the story of what was before the deployment of COMS. Our warehouses hitherto received orders via email, meaning once orders are ready and they're on spreadsheet, we send them via email to the warehouse managers. And once these emails are received by the warehouse managers, they make a download of these orders, of these spreadsheets, and begin to process them by opening the spreadsheets and entering each transaction line or each order line manually into the warehouse management inventory, the warehouse inventory management tool, the WMS. This was done by the warehouse staff, manual process. Once that is done, they also conduct what we call gap analysis. The gap analysis was conducted to check for variance. This variance is looking at the order approved against the stock in the warehouse. There must be 100% agreement before the pick and pack must commence. So this gap analysis was done manually offline to achieve that. And once this gap analysis has been done, and if variances are identified, this is communicated with PSM for review and adjustment of all facility allotments or all facilities orders. The PSM team now review these orders. We make adjustments and share review orders with the warehouses. These often create a challenging and delay lasting as long as 72 hours. And this also create a problem of version controls with respect to approved orders. And once this is done, the warehouse now begin to modify orders or re-enter all the orders into the WMS before pick lists are created for the commencement of pick and pack. So that was the process before. With the deployment of COMS, we have achieved the following. We now have one central platform for order management with the successful integration of NHLMIS and WMS, warehouse management systems. Orders are now managed from one digital central platform, in this case, which is COMS. All parties, supply chain operators, work from one data, meaning all parties involved order management work with data from one cloud-based system. This has successfully eliminated cases of inconsistency, cases of data inaccuracies, etc., etc. With this deployment, 48 to 72 hours of work has been saved with each LMD cycle, meaning pick and pack commences within an hour of receipt of orders, and this has reduced the lead time for LMDs, because integrating these three platforms provide that visibility for ease of reconciliation of approved orders and warehouse stock. What we have also achieved is a quick response to data requests, improved data quality, quick response to data requests, more efficient process that impact on on-time delivery and order fill rates. And all these have successfully or has contributed to the strengthening and increase in confidence in GHC supply chain operations by donors and the government of Nigeria. We have also gained improved lead time for completion of the LMD. The level of effort used in generating the pick list has reduced drastically. This is because the process is now fully automated 100%, has eliminated manual data entry. And this has positively impacted the general lead time for completion of the entire LMD process. Deliveries of commodities are confirmed in real time. This is also an output of the deployment. With the EPOD, confirmation and monitoring of pickups and delivery can be done in real time by the 3PL, and this is visible to everyone, especially the PSM operators at the same time. Reduced data entry error. The elimination of the manual entry of the LMD orders into the WMS have reduced data entry error because the system does this automatically. The system is able to automatically pick batch numbers, manufacturers, expiry dates for pick and pack. So that is what the COMS has addressed in terms of output, looking at before and our current status, and many more gains that we have achieved with respect to the other part of that. But what were the key lessons that we learned in the deployment of this innovative solution? Number one is talking about multiple system integration. So when you have multiple systems to integrate, it's complicated if not done properly. And part of the lessons that we've learned in the journey was harmonizing the master data, defining the data elements, data dictionary, and defining the proper API documentation protocols. All these contributed to the successful rollout and was a lesson for us. The second lesson was delivery cycle times, because Nigerian logistics system was built and the deliveries were scheduled bi-monthly. This limits the pace of development, especially of new features and bug fixes. So we had to align our rollout and deployment to the delivery cycles. Change management was also a lesson. Some of these challenges with respect to state management can be addressed by bridging the communication gap between different stakeholders to improve understanding of the requirements and the processes. Early communication, early engagement with end users to understand the process itself goes a long way in bringing about acceptance of change and embracing this tool. Software limitation was another key lesson. Implementation is sometimes limited by software development lifecycle. Features requiring major customization are sometimes delayed as a result of this. Another lesson being a well-articulated vision. Articulating a clear vision, key goals and objectives from the beginning is vital for implementation. And that helps us clearly in this development and in the deployment of comms. Communication. Clear communication throughout the process is important to achieve set goals as well as set objectives. Documentation along with monitoring and tracking. This ensures outputs align with set objectives in all phases of development and implementation. Developing a master data set. It is essential to develop a master data set for both the products and the service delivery point or facility to avoid any supply chain delays or disruption, because these are critical data sets that support the processes and provide that needed visibility for the operation. So these are the lessons that we learn. At the end of it, what were those achievements that we recorded with this optimization, with the rollout and the deployment of this tool? Number one, comms has provided one central platform for order management, a key element in overall improvement in logistics. The second adjustment is this: data now sits in a cloud-based system and is easily accessible from anywhere for those who have been granted access. And this has helped eliminate inconsistencies and improving the need for, and has improved the need for gap analysis and multiple revisions, and address multiple revisions of orders. Orders are managed from one digital central platform, and this has given us savings in time and improvement in efficiencies. And the last but not the least, within an hour of receiving an orders by any warehouse or any of our distribution center, pick and pack commences, leading to a reduced lead time in last mile deliveries. What are those additional quantitative achievements that we have received? Number one, the system itself has brought about 72 hours saving every cycle with respect to time. That is, 3 days is being saved every cycle, which translates to 18 days per annum. And that is about just the time for annual leave for a staff. Beyond that, we have received an overall 38% unit cost reduction in our last mile delivery processes. And this translates to about $2 million in cost savings annually across the system. According to the recent benchmark cost that was done, looking at the other features that have been deployed in comms, where they include route planning, route optimization, contract management, and using the platform to evaluate costs that are due to vendors for ease of analysis and service. So these are the additional achievements that the bench cost assessment has revealed to us. Overall, this is our story. This is the innovation that has been brought, that has brought about, a change, a complete change in Nigeria supply chain landscape. Thank you, and God bless you.
Thank you. That was a wonderful presentation. We have just about 10 minutes for Q&A. I would prefer to have the judges go first. So maybe Azuka, this is from Nigeria. So you may have some questions for your fellow countrymen. Azuka, are you there? Okay, let's go perhaps. Azuka, you're muted.
Yes, I'm in transit and it's dark. I'm going to remove my video, but can you hear me?
Yes, we can hear you.
Okay, pardon me. It's a bit late. Yes, I'm leaving the office. Okay, but thank you very much. Another very interesting presentation. Again, anything that speaks to the last mile is always something that I would say is of high interest, not just to me, but to everyone. And seeing the comes to, as something that, particularly the potential of cost reduction, the $2 million cost reduction is also exciting to see. Linking that to what you said about change management, again, because I know that in countries like Nigeria, the idea is that technology is procured by government. So I want to understand, having this result, has this been presented to the Federal Ministry of Health or to the state ministries of health? Do you think this is technology that they will pay for, seeing the opportunities in adopting the tool? So that is my question. I hope you got that.
So you're right. Sustainability is always an important, question. It's something that we should consider when we're rolling out these new technology solutions. Right now, the technology is being deployed as part of the donor-funded supply chain. My colleague Abubakar referred to the donors whose commodities were actually distributed in the global fund, USAID. And so right now, they're the ones that are paying for the technology solution. But I think that what we have done here is what we call a proof of concept, showing the possibilities, showing the cost savings that are possible with technology. And I don't think that it's right to tie ourselves to any particular solution. But once we see what is possible, we can further investigate other potentially maybe more cost-effective technology solutions. Farms has saved a lot of money. Like Abu said, it's over $2 million a year. But when you look at the cost of the solution, it might not be something that, that a cash-strapped government will be So I think it's a proof of concept. It shows what's possible when running an optimized supply chain, especially with the private sector, like we're doing in all of our areas, and not government, but we work with the private sector. So it shows what is possible, and I'm sure that we'll work with the government, the MPSCMP, to look at this solution and possibly look at more cost-effective solutions that actually bring about the same benefits.
Yeah, thank you. I think it was a little bit difficult to get all of the points across. So see if you can, adjust your phone, because sometimes it was coming in properly, sometimes it was fading away. I don't know if it's a bandwidth issue or is it just the how you're speaking into the phone. But let's ask Kelly. Do you have a question?
Yes, thank you. And thanks so much for the presentation. I was wondering if you could speak a little to what the governance process was for decision-making, both in terms of deciding what platform to use, and you spoke a lot about significant customizations and the decision-making around that, or how it should be customized and the trade-offs between that and time. What was the way to make key decisions about the implementation of the software?
Yeah, that's an interesting point, Kelly. I hope you guys can hear me better now. I'll try to speak a little louder. Can you hear me?
Yes.
Okay, great. The system we're talking about here, COMS, is actually made possible by the Nigerian Health Logistics Management Information System. What do I mean by that? Previously, facility logistics reports were collected in by paper. We had to use the postal service to send photocopied sheets of paper hundreds of miles to a central location. That does not happen anymore. And the value add that we have brought about with COMS is only possible because of the NHLMIS. And that's really why I want to focus the question on governance. The NHLMIS was a system developed funded by multiple donors, the Global Fund, UNFPA, USAID, working with the government. And so all the donors came together, put their funds in, and a committee was set up that helped to manage the development process, that helped to prioritize features. All that was done with the government and with the different stakeholders, the different funders like we spoke about. That was managed through a governance process. For COMS, it is still a mostly internal, which correct me, internal. I'm saying that the value add is on top of NHLMIS, but it's still mostly internal to GHSC-PSM and Chemonics. And it only covers the facilities that we deliver to at the moment. And like I said, it's just a proof of concept that shows what is possible by optimizing the supply chain. And we will likely go through the same process that we did with the NHLMIS, build additional value on top of that to bring these benefits that we have achieved with COMS to the larger supply chain in Nigeria.
Yeah, thank you. Stephen?
Yep, thank you. Great presentation, and super exciting to see the progress that you've made. The last time that I was in Nigeria doing supply chain TA was like 2014 maybe. So I'm a little bit rusty in terms of where things are. But I think one of the things that was noticeable, at least then, was I think the stark difference between the relatively high performing supply chains, supply chain for HIV through programming versus things like the drug revolving fund and essential medicines and other pieces, right? And I think it does relate to this issue of sustainability and sort of long-term contributions to the rest of the health system in terms of improving other parts of the supply chain. Would you say that beyond the HIV program, that this solution has also managed to either promote innovation or better supply chain management in areas beyond the scope of the project, and or are there plans to do so? Thanks.
Yeah, so this is Abubakar Mohammed. Thank you, Stephen, for the question. So this innovative solution covers beyond HIV program. So the NHLMI itself houses vaccines, supply chain. It houses HIV/AIDS, malaria, TB, family planning, and maternal and child health. So these are the programs that are resident inside NHLMIs. And it's this Nigeria data repository that comes Block 2 has been integrated into. So in terms of output, in terms of the delivery services that we do, both for Global Fund and for GHSC-PSM, the last mile delivery covers HIV, malaria, and family planning. And these are the facilities that translate to about 17,000 service delivery points that we reach, every 2 months across the country. So it's more encompassing, and the expansion will be done as we engage government, as we collaborate with government to add more programs in terms of last mile.
Thank you. Pascal, you have any question? You're muted.
No. Actually, the question I had was what Satish was asking in the
So
in the chat.
So Satish, do you want to unmute yourself and ask your question?
Sure. Thank you. So like I said, just curious to know if the project got a chance to evaluate any existing solutions. In my experience, we've seen that bespoke solutions, while they address specific pain points, a long-term sustainability becomes a challenge when the project team moves on and it transitions to the government counterpart. So just wanted to hear what are the plans there and what were your thoughts there? Thank you.
Okay, so we went through a vendor selection process, for comms, and the vendor that we went with was the best value, and it provided what we needed, the benefits we needed to get from a supply chain control tower. For the NHLMIS, it was slightly different. The platform was already in use by the vaccines program, and it was working. It was really a good job for them. And so the donors, the stakeholders, like I said, UNFPA, Global Fund, and the government of Nigeria came together and said, hey, okay, look, this is working great for the vaccines program, and we want to adopt it for use for the rest of for the other programs in the country. So that's for NHLMIS. That's a custom-made system built from the ground up, and it's run as sort of a software as a service platform. The government doesn't really need to worry about any infrastructure or anything. We just pay for the service, pay for support, and we get access to that platform. But you've asked a good question, and some of the things that are happening in other countries are quite interesting, especially around open source. When we talk about open LMIS and the product catalog management tool, we're keeping a very close eye on these developments. And if we see the opportunities to use any of these more open, more free, not as in peer, but open source, freer solutions, we will certainly consider them and adopt them. Thank you.
So follow-up question, Abubakar. So are you suggesting that the government is pretty open to software as a service model?
Well, right now, the donors are paying for NHLMIS, but the government is completely on board. We've handed the system over to the government. So management of the NHLMIS is done by MPSCMP right now. The payments are still being made by donors, but it's certainly something that can be handed over to the government in future. When you look at the value that is being provided, and the cost, a facility cost, for example, it is really quite minimal, and it should be something that the government of Nigeria can cover pretty easily. The cost of the system will also go down gradually over time as some of the more expensive parts of the service, mainly support, level 1 support, level 2 support, are handed over to the government and taken over by government staff. And that will drastically reduce the cost of the system. And you'll find that the per facility cost compared to the value that we're getting from a system that can be used by multiple programs and all facilities in the country is really quite minimal.
Great. Thank you. Maybe one last question from the audience. If anybody wants to ask, just unmute yourself and ask. Anybody? Going one? Sure.
I have a question for the first team, and it has to do with, are you observing any capacity to produce PPEs in sub-Saharan Africa?
That's to us. Yes, we are actually. And in fact, one of our goals right now is to procure from suppliers on the continent in Ethiopia and in Kenya. So it is proliferating now. It wasn't the case in June, July when we made the first orders, but for sure it's a huge priority. I think there's a lot of potential, and in particular, NEPAD, I think, is the organization on the continent that's focused on that. So yeah.
And a quick follow-up on that. Are you going to be using community health workers for the vaccination? Should that be possible?
It depends. For sure, it's the role they will play now is to build confidence. The main concern we have is the amount of misinformation that's quickly going around. And so it's sort of educating, ensuring there's awareness of the right information, for sure is a very important role, because there's no point distributing vaccines that people won't take. As far as the actual delivery, it depends on the context. There are some places where community health workers are trained to deliver vaccines, but it just depends on the training that they get. And it'll depend, of course, on the vaccine itself.
Thank you.
Wonderful. Anybody else has questions, judges or audience? I know we are over time, but if you have any, we can entertain that. No? Going once, going twice. Wonderful. Thank you so much. Really a big round of applause to the both teams that presented. And
yeah, thank you.
I have typed in the, please, I know it's late in some places, but please come and join us for the networking session for another 15-20 minutes or so. At least we get to see each other and say hello. With that, we'll see you tomorrow then, if I don't see you in the networking session. Thank you so much. Thank you, judges. Yeah.